So hi to everyone who's just joining us. I'm just going to give it a few more minutes to let people sort of trail in, and then we'll begin. Great, okay, well thank you everyone and welcome to today's webinar from the Quality Network for Forensic Mental Health Services. My name is Kate Townsend and I'm newly appointed Programme Manager for the network. So today's webinar is on secure care and the importance of family and friends. So this will cover experiences from two of our fantastic care representatives, Nila and Sheena, and they will share their experiences of having their loved ones in secure services and the opportunities and barriers that they've faced. Following on, hopefully we will have Melanie Higgins, who is the Clinical Director for the Secure Division at Ashworth High Security Hospital. I say hopefully because she hasn't quite managed to make it on just yet, but we're working very quickly and quietly in the background to get her on. So Melanie is, as I mentioned, she works at Ashworth High Security Hospital, and she will be discussing the realisation of reaching out to family and friends and what a huge impact that had on the patients. And finally, we'll be hearing from Rozak, who will be discussing the hot topic of open dialogue, the systemic person-centred model of care that involves working with patients, families and networks to enable a more collaborative approach. So Russell is a consultant psychiatrist and also medical director for North East London Foundation Trust. So as you can imagine, this is quite a jam-packed lineup, and we're very excited to have everyone on today. Everyone's kindly agreed to speak for around 10 minutes to allow time for question and answers. So I don't want to take up too much of their time, and I just want to welcome everyone and thank everyone for attending today. So I believe it is vital work to promote and encourage the engagement of family and friends within all mental health services, but particularly within the specialty of forensic, which can often have more complex relationships between family and friends and patients. So I'm very excited to hear about today's speakers. I just want to mention that the webinar is going to be recorded and made available on our website, and please encourage everyone to use the question and answer function at the bottom of the screen. Please send in the questions as and when, and we will have time towards the end to focus and facilitate the questions to the speakers. So without further ado, Jem, if you could kindly stop sharing the holding slide, and we've got our panelists of speakers here, and we will begin with Nila.
Thanks, Kate. Hello, everybody. I'm a carer, and I'm going to talk about opportunities for my involvement in secure services. It's really good that opportunities for family involvement in secure services have been developing in recent years, and this is in recognition of the fact that carers have skills, knowledge and experiences that can make a positive impact on their loved ones' care and treatment. And indeed, the involvement of carers is now regarded as vital to their loved one's recovery. And since the publication of the Carers Toolkit in 2018, the involvement of carers has become mandatory in secure services standards. And as the mother of a man who's been a user of mental health services of all types for 19 years, including inpatient secure services for the past 4 years, I regard this as a welcome and necessary improvement. because over the years I've had some very adverse experiences as a carer, because I was generally regarded as having no relevance to my son's care, especially when he was in hospital. And this is despite the fact that my son has always given consent to the sharing of information with me, and in fact welcomes my involvement himself. So have things changed? Well, I think yes, in some ways, and no, not in other ways. In my local secure service, there have been some good new initiatives in the last 5 years that provide involvement opportunities for carers. There have been carer and service user involvement coordinators appointed and a carer lead. And through them, I've been able to attend a carer support group, a carer focus group. I've been trained as a trainer and as an interviewer. So I've contributed to staff induction and staff recruitment and academic meetings. And I've spoken at a regional conference last year, and I've been a member of a variety of specific stakeholder groups. And now I'm a peer reviewer for the Quality Network for Forensic Mental Health Services and a family representative on the Quality Network's advisory group. So where is there still a need for change? I find that there's a significant dissonance between the type of family involvement I've just described and family involvement in clinical practice. There still exist barriers to family involvement in clinical practice in secure hospitals. And my local trust's Carers Charter reads that we will value the experience and expertise you have, and we will work with you as equal and expert partners to give the best possible care. And we will recognise that you are integral to the whole care plan, initial assessment, risk assessment, reviews, discharge and recovery planning. However, opportunities to be involved in this way don't exist as a matter of course. And over the past 4 years, it's been rare for anyone involved in my son's care to contact me spontaneously, nor to ask me questions about my son. And any involvement on my part has largely been initiated by me. So where are the opportunities to be integral to my son's care plan? There's a weekly or fortnightly ward round, depending on what ward he's on. There's a CPA every 6 months. There's a hospital manager's hearing once a year. And there's a mental health tribunal every 3 years. I have received mixed messages about whether or not I'm welcome to attend ward rounds. And if I do attend, it's a matter of being present for around 10 minutes at a meeting where discussions are held and decisions are made when my son and I are not present. And these attendances involve a 30-mile round trip for me. And compared with what's involved for other families, that's quite a small amount of travel. And the only other regular opportunities for family involvement, the 6-monthly CPA, the annual hospital managers' hearings, and the 3-yearly tribunals. These are hardly satisfactory. And also when I talk to carers on review visits, I find typically that most carers aren't aware that they can attend or contribute even to these meetings. So it really doesn't surprise me that so few carers are involved with their loved ones in secure services, as in my experience, it takes a great deal of relentless determination to find a way in. And at present, at my request and following quite some persistence, I have in the past 2 months established a regular weekly contact with one member of the current team. And this is good. And I feel for the first time that someone is genuinely interested in my views. However, I continue to be excluded from team discussions, and I have no influence over decision-making in relation to my son's care. And I would say generally that there's still not a culture of valuing family involvement in clinical work, and care awareness is poor, and attempts to include families seem half-hearted, and there's little knowledge amongst the staff of the requirements of the carers toolkit, and little real appreciation of the benefits of carer involvement. So how can we understand and overcome these barriers to our meaningful involvement? A few months ago, I had a conversation with a nurse on my son's ward about my struggle to have a voice in his care, and particularly important as I'm the only person who can explain the events that give meaning to his problems. And I gave her examples of how it's evident to me that despite my efforts, and even though my son's been in the hospital for almost 4 years, key members of the team still don't have the crucial knowledge of nor understanding of the significant events in his life. And she told me that the team needs to be able to work independently of carers, just as a medical team would not expect carers to be involved in their work. And I think that's where the problem lies, and that in forensic inpatient services, mental health problems are still regarded primarily as biological illnesses, and the treatment teams are structured hierarchically along the lines of medical teams. And all patients have a psychiatric diagnosis, and for the vast majority, the primary intervention is medication, usually prescribed long-term. And these psychiatric diagnoses are believed to explain what's wrong with patients in terms of underlying illness resulting from neurochemical imbalance that the drugs purport to correct. And insufficient attention is paid to what's happened to patients in their lives, the significant events that have led to their problems and give meaning to their problems. And the fact that the idea of neurochemical imbalance has no scientific basis, as no researcher has ever found evidence of it, is commonly denied or ignored. And also denied or ignored are the serious harms caused by these arguably unnecessary drugs. And these harms include brain damage, metabolic syndrome, and a reduction in life expectancy of up to 25 years. So there's rightly much current debate about the validity of this biomedical paradigm and concern about the iatrogenic harms caused by the long-term use of psychoactive drugs. And alternative paradigms are gaining attention, such as those outlined in trauma-informed care, open dialogue, the Hearing Voices Network, and the Power Threat Meaning Framework. And there is a more obvious and natural role for family members in these emerging approaches, and particularly in open dialogue teams where hierarchies are flattened, families are fully included, all voices have equal validity, and all decision-making involves the patient and their family. And studies show superior clinical outcomes for open dialogue, as well as increased job satisfaction for staff and improved staff retention rates. So it's important that mental health professionals are open to the debate concerning ways of understanding mental distress and treatment models, rather than presenting neurochemical imbalance, psychiatric diagnoses, and the efficacy of psychiatric drugs as undisputed facts. And I think we need a huge shift in the way services are organised to move away from the predominant biomedical model towards the primacy of these alternative paradigms. And this will not only enable truly meaningful family involvement, but according to research findings, it will also achieve, as I mentioned, and it's worth saying again, the benefits of better recovery rates for patients, increased job satisfaction for staff, and improved staff retention rates with less iatrogenic harm. Thank you.
Thank you very much, Nuala. That was fantastic. So I think what we'll do is save the questions for the end, and I will hand over to Sheena, if that's all right.
Unmute. It's always a difficulty, isn't it? Hello, everyone. Nuala said there are some services where care engagement is moving forward, and I do believe that's true. But I also agree with her that any meaningful involvement with our relatives' care has a long way to go. We know from the research exploring family care involvement in forensic mental health services, which helped inform the carers toolkit, that the most important thing that carers want from services is to be aware of how they feel. Many are traumatised by their relatives' admission to services, and this is still not being addressed. Few services have a protocol on how they work with carers at the point of admission. This would enable carers to trust the services. Where it is addressed, however, it seems to be done mostly by social workers who are prepared to proactively make contact with carers, maintain that contact, and work with staff on the wards. This is despite patients not wanting their relatives involved. Services have a duty of care to carers, which does, I'm afraid, seem largely overlooked. We should be seen as assets to the service. I think Nuala would agree if I say we hold what's happened to our relatives in our head and who they are as people in our hearts. And that's a rich body of knowledge that isn't yet tapped into. For me, meaningful involvement demands respect, regard, and all parties working together for the benefit of the patient. What stops this happening? You know, a few thoughts. I think there are 3 barriers. I'd like to look at culture, attitude to carers, and confidentiality. The biggie. The culture of secure services, though, or should they be renamed secret services? No one knows about them. People are reluctant to talk about them. How you get out of them remains a mystery to carers and patients too. One of the questions we ask patients in reviews is, do they understand what they have to do to move on? Why should carers not understand what needs to happen? If my relative was admitted to a general hospital with a broken leg, I'd know the process he would need to go through in order to recover. If you understand what's happening, you are better able to deal with and trust the people who work with your relative. A few years ago, I was invited to a carer support group at Ashworth to listen to a talk about No Force First, a programme which aims to reduce restrictive practices. I found it really moving to hear family members talk about their experience of their relative being in seclusion. Things that happen inside secure services impact on carers and therefore other family members. I don't know any carer with a relative in a secure service who hasn't woken up at some point one morning feeling physically sick and unable to face the day. And it comes in waves depending on what's happened with their relatives. The service where my son is held an open day where we were shown around the whole service and then had tea and cakes on the ward, and he was able to show me his room. I could sit for a minute there, the place where he spends his time, and take that picture back in my mind. I also got a sense of the pride he had in the way he'd organised his room. You know, that's what families do. They want to show each other what they're doing. So be brave. Open up your services. You have nothing to lose, but you have the respect and trust of carers to gain, and the pride of the patients in showing relatives around their home. It's always said that the patient is the most important person, and I don't believe any carer is going to argue with that. But beyond the patient, there is, in most cases, a family who care, but attitudes to carers, as Nuala said, are poor. When you see a patient, do you think about their family? You see, the thing that struck me recently with COVID-19 is how much has been made of not seeing relatives and being cut off from them, and how everybody suffers. That's the norm for carers in secure services. Until recently, we couldn't Skype either. Just think about how that must feel. The way we are viewed seems to be determined by our relative's illness or offence, because it feels we're guilty by association. It must be our fault, and this is one way of keeping carers at arm's length, because we do feel guilty. That's being human. Any parent can recognise that if something happens to their child, we ask ourselves why, and think there might be something we could have done better. Over the years, professionals have said to me, we have some nasty carers here, and some of our carers have a mental illness themselves. 1 in 4 people have mental health issues, 1 in 4. On a review earlier this year, a professional said, if a patient doesn't want their relative involved, we wonder what that person must have done to the patient. I am therefore under suspicion. The 5-year forward view talks of parity with physical health services. I can't imagine ever turning up to A&E with a son who's broken his arm, and the first thing staff think is that I must have pushed him off a wall. Attitudes to family members need to change. What do you really know about the carers in your service? I was fortunate enough to visit services in the Netherlands. They regularly hold family days, and if a visit is difficult for a family, they invite them in to prepare a meal together. But I think it also has to work both ways. Staff need to talk about the difficulties they have with carers, and then we look for solutions together. Otherwise, we may well be disabling patients. Families too can be damaged by secure services because we are never seen as a unit that needs understanding and guidance. And finally, confidentiality. The Carers Toolkit has a quote: "Confidentiality issue needs to be sorted out because so much is hidden behind it. Power, fear. If you go into a general hospital, you are asked if there's anyone you'd like to call. But in mental health services, patients are immediately informed about confidentiality." Where did this come from? Where did this attitude come from? Does it come from a time when families had their relatives locked away and they were never mentioned again? Does it come from the shame and stigma surrounding mental illness? Have we not got beyond that yet? You know, we won't tell anybody here, you don't need to know anything. It's that secrecy again. Sometimes I think services need reminding that these are hospitals where people recover and families want to support that. The word confidentiality seems to strike fear into professionals. So let's try and unpick it a little. I need to say at this point that my son doesn't want me involved in his care and treatment. He tells me what he wants me to know. And as a family, that suits us. We feel we're respecting him as an independent adult, and he feels he's his own man, and that's important to him. But I think that sort of relationship isn't recognised by services. The other thing, what does involved in treatment mean? How do we define and measure it? Nuala doesn't feel she's involved, and her son has actually given permission. I much prefer the term information sharing for the benefit of the patient. If we think of it like that, perhaps it will be easier for us to work together. But whatever you want to call it, there's just 5 points to think about. Number one, service users do not have the right to prohibit a professional from engaging with a carer. When is it ever inappropriate to talk to a family member? Carers can have information that can enable services to work more effectively with the patient. Two, carers can be given general information, advice and support. What does that mean? I don't really know. I'd actually prefer that psychiatrists learn to speak generally. An example, my son told me that his medication had changed to olanzapine and amisulpride. So I went to talk to his psychiatrist, and who immediately went, "I can't talk about it." "Yes, you can." I said, "My son has told me this." "Oh, well, yes, but he doesn't want you involved." I said, "Well, generally speaking, when would a psychiatrist prescribe those two medications together?" Then he explained it to me. So psychiatrists, if they can find a way around of actually speaking generally to assure carers. Number three, carers can give information. We give information in good faith that it's used wisely. This is important when people move between services. Unfortunately, in my experience, it's often ignored. Number four, professionals can ask us questions, but as Nuala pointed out, they rarely do. You know, that conversation, we're thinking moving your son to low secure. What do you think? You know, that's a normal conversation that would mean that we felt involved, that we were involved, and it's just a conversation. And it's a question, and it makes you feel valued as a carer and involved. And the last one, 5, if information is known, it is no longer confidential. And that is the biggest problem of all. My son will tell me things about his medication, but then nobody can talk about it because it's confidential, which is complete nonsense if you think about it. And why is it so hard to have a human exchange about our relatives when we both have the best interests at heart? You know, if somebody has the answer to that, please put it in the chat box. And finally, most important for me anyway, at the moment, is I'd like to understand why carers involved in the index offence are not automatically involved in their relatives' care. My son is seen as a mentally disordered offender and I'm seen as a victim. I've never seen it like that. My son was ill. When well, I'm the last person he would want to hurt. The judge saw it like that, so why do services see it differently? We're separated by the system, left struggling to make sense of what happened. Common sense tells me we need, as a family, to sit down as soon as possible after the incident so we are enabled to understand each other's perspective of what happened and move forward together. You know, is that too much to ask? Services are commissioned to maintain family relationships. However, I am optimistic at the moment. With the introduction of Skype, I can bring my son into my home. I can show him what he's made in woodwork and that it's being used, and it keeps us together. And I don't want to lose that facility at all. So thank you for listening.
Thank you very much, Sheena. That was absolutely fantastic. What good insights into confidentiality. So on to our third speaker, Melanie Higgins, who is here from Ashworth Hospital. Melanie, are you there? I can't see your video.
There, can you see me now?
Absolutely.
Can you hear me, everyone? Can you hear me? Yeah, fine. Shall I get started?
Please do.
Yeah, people can see my office, rather nice pink colour with lots of trees. That one's about to fall over. Okay, so hopefully I can try and be a sort of a more humane face for us forensic psychiatrists. So my name's Dr. Melanie Higgins. I'm a consultant forensic psychiatrist at Ashworth High Secure Hospital. And I've been working there as a consultant for 16 years. And I've probably been in forensic psychiatry for another 6 on top of that, yeah. I always wanted to be a psychiatrist. I felt I had a natural ability to engage with patients and families, but I have been behind a 40-foot wall for 16 years. And I think being invited to take part in this webinar gave me a chance to reflect on how things are subtly different at Ashworth in the way that I've been able to interact with families. We have there's 200 men that we care for, and there's probably a relatively small group of highly active family members and carers. And the main barrier of some degree is the wide geographical spread. So although we take patients from the northwest, parents, families, carers can live almost anywhere in the UK. It's a very different setup from being a general adult psychiatrist. Often patients in the general adult psychiatry services will be brought in by their family members and you have direct access. You certainly have to try harder when you're behind the wall to reach out to people, especially as a doctor. I have 24 patients, and I'd be lying if I said I had very close contact with all the family and carers who are involved in my 25 patients, yeah? But every PCTM at Ashworth has a dedicated social worker who are an absolute key part of that team and who do carry and deliver most of the first point of contact with families and carers. If I'm being honest, in the early part of my career, that interaction with the social worker is where I would generally have left it. And I would not have considered much need for my involvement directly with those who are close to the patients, yeah. I have definitely come to a different position as I've gone through my career, and I believe that my delivery of care and the experience for the service users, carers, is the better for it. And looking back, there have been a couple of real turning points which really left their mark on me, and families who've left their mark on me over the years. And I'm just going to quickly do 2 anonymised summaries of that. The first and most pivotal was the care of a young man who had a very treatment-resistant schizophrenia, who had no forensic history, but had come up via levels of security against the background of a stable family. He was probably one of the illest men I've ever cared for, and had a combination of florid psychosis. He'd been catatonic at times and had the most extreme levels of deliberate self-harm, to the point of this being at a life-threatening degree. At one point, the patient was potentially likely to die due to his deliberate self-harm at a local hospital. It was before my time of caring for him. His mother cannot travel due to post-traumatic stress disorder, and additionally lived hundreds of miles away from Ashworth. Nevertheless, a family member drove his mother to the ITU, only to be met by the restrictions of an unannounced high secure visit. Essentially, she was initially turned away. Although subsequently allowing the visit and the patient surviving the surviving the illness, the therapeutic relationship between the mother and Ashworth Hospital completely collapsed, and there had been no meaningful contact with her for many years. At the time I was caring for this man, I was struggling to improve his mental health, but I decided that if I was only able to slowly make progress on that front, perhaps I could repair some of the damage that had been done on the family side, which is what I set out to do. Slowly, via phone, the relationship was rebuilt, starting by me apologising unconditionally for what had occurred during the spell in ITU. I remember a particularly poignant time when the mother told me and asked me, "Is his face terribly scarred?" I must confess I was very taken aback by this, but it gave me a first insight into how the isolation and separation of family members and carers can lead to all manners of unnecessary concerns and unneeded worry. I arranged for a photo to be taken in seclusion. Again, I remember vividly at the time that my male consultant who I worked with paired up on our wards bemoaned the fact that the background was rather of a dreary segregation room. But I said that I was unconcerned. This man's face was fully visible, unharmed, unmarked, and I could hardly pretend that he was elsewhere with a picture of a tropical beach behind him. Yeah. I was able to hand his regular care over to the social worker during a period of extended leave I had, maternity leave, and I later learned that his mother had the photograph framed and had put it on her mantelpiece. There is also one more piece of hope I would like to share. It'd been some years since I'd looked after this man, and in the meantime he'd been established on clozapine and had a very, very tight and robust package of care around him. We did something rather unusual, and this was never going to be an easy move to medium security, and we invited the one medium secure unit who had offered to offer him a bed, the staff and the ward, to spend a number of weeks put up in hotels around Ashworth to get to know this man. And we did vice versa when he moved to the medium secure unit. Yeah. It was quite a moving day when he went down. They stopped off along the M6 to allow him a break, and he commented we took him to a duck pond. And when he arrived at the medium secure unit, what was really moving was that he went straight over to the safe that was built into this very nice ward, which overlooked fields and cars and all the things you can't see from Ashworth, and asked what the safe was for. And our nursing staff said to him it was to keep your money. And he said, "Money, like real money you can have in your hand?" And they were just made up. And although we told him it was for a visit, he actually said when we got there, "Can this be my forever home?" He made the transition, and I've had feedback from his consultant at the medium secure unit that he's practically flying. So that was a lovely outcome, but taught me very much about the importance of families and friends and carers. There's one more vignette I'd like to give, and it's I'm currently working on an exceptionally unusual case of a man who was admitted again due to serious violence in a medium secure unit. He's in his 40s, he's exceptionally tall, he's of mixed race, and he is the epitome of a phrase which is used to set a tone, which is of being not in our service, but historically considered big, black and dangerous. Yeah. There's been a lot of diagnostic problems with this man, and previously in the community, almost predominantly diagnosed as personality disordered or having a drug-induced psychosis. Drug use escalating, and the focus, as far as I could see in previous placements, of getting him out of hospital as quickly as possible. But hanging around was a diagnosis of a temporal lobe epilepsy, which wouldn't quite fit with our presentation. He was always very hostile, always at a knife edge of violence. And he was first admitted 18 months ago. I was not his RC, but one of the very senior trainees was acting up underneath me. And he did the single most important thing that happened to this man's care and treatment that hopefully will allow us to move forward. And he took a history of this man's mother and sister. It's always a bad sign, I think, when family members, and in this case his mother and his sister, are glad that patients are now admitted to Ashworth and tell you something about the very tricky journeys they've had. But that was the case for this family. I had the chance to repeat the experience when myself and the social worker met again at Ashworth with the mother and the sister, and on this occasion, a very senior neurologist, to take exactly the same history from the family. And the details at that point that emerged were crystal clear. Their brother and son had been a kind, loving family man. They described him as a gentle giant. He had been a taxi driver, and he had been the life and soul of his family. He wasn't married and didn't have children of his own, but the rest of the extended family coalesced around him. But he'd had a couple of seizures as a child, but in his adult life later on, in the last 10 years before he came to us, so in his 30s, he'd began to experience seizures and profound deterioration in his functioning. Particularly moving that day was when his sister gave an account of being assaulted by him. And there was something about the way she said it that made me ask if she thought she was going to die, and she thought that she was. To be fair to them, it was a great weight off their shoulders to be able to be taken seriously. And the diagnosis of temporal lobe epilepsy has, of course, completely changed the direction of travel for us and for me as a clinician at Ashworth. And I'm due to have a Skype call again with the mother and the sister tomorrow to talk about treatment options, which are tricky but not insurmountable. And I guess that, I'll be able to share my plans with them at that point in a very direct way. I'm conscious of the time. I'd just like to finish my own reflections by saying that the journey I've had with my families has been profound. Yeah. As I said, I don't have that relationship with all of the patients under my care, and nor do I need to. Yeah. But I had a Skype this morning of a carer who Sheena knows well, and she was going to attend this webinar, but she's rightly decided that her mental health is best served by having a walk without seeing me again. Yeah. And what happened last week was that unfortunately a son had a serious deterioration, albeit brief, in his mental state. And we had a very honest and open conversation about the difficulties we've been having, particularly during COVID. Yeah. The COVID has had one good effect on the high secure hospitals in that it has absolutely accelerated the use of Skype. It's not as good as seeing your family member, but there are some patients that even in the families in the non-COVID era that couldn't have face-to-face visits anyway, and we will make sure that Skype remains part and parcel of our offer, even when face-to-face visits open up, which they are doing. I regularly phone an 89-year-old mother of one of my patients, who is one of my greatest sources of knowing if her son is ill or not. And when she rings the secretary and says I'm not happy how he is, I immediately ring her. So do I need to be actively involved in all my patients' families and carers? No. But what I have learned is that open communication, especially when things are not going well, can significantly improve a picture, even if, as was mentioned by one of the earlier speakers, my more traditional medical and psychiatric knowledge and experience and hope is struggling. So those are my experiences.
Thank you very much, Melanie. That was really, really interesting. What an interesting insight into Ashworth. So thank you very much for that. And finally, last but not least, I will hand you over to Russell.
Thank you. So hi, just to introduce myself briefly, I'm Russell Rozak. I'm a consultant psychiatrist in North East London, and so Director of Research, Associate Medical Director there. I've been interested in open dialogue for a number of years, helped train people to learn open dialogue, and I'm helping to lead a national multi-centre trial into the implementation of open dialogue in the NHS, and that's particularly into adult services. But I can maybe say a little bit also about a little bit of a pilot that took place in our own trust in one of our secure units in open dialogue as well. So the first foray into secure services for open dialogue, while most of our research is actually happening in adult services. I'll start just by giving you an overview of what open dialogue is. Open dialogue is a model of care that's different from the perspective of really proactively engaging the patient's network and their family and friends as part of the treatment process. It's not anti-anything, it's not anti-medication or medical model or any of those things, but it's pro-collaboration, it's pro-dialogue, as the name might suggest. It's about trying to involve everybody in actually a very proactive way, which is different to the way we traditionally work. So prior to open dialogue kind of work myself, I tended to meet family and friends of patients in ways that people tend to do, which is sort of occasionally and as a little bit of an afterthought. But the primary treatment was happening to the individual themselves. We'd take the individual out of their environment, try to work with them, and then send them back to their environment. And then we'd, of course, find that they'd end up often coming back. I used to work in PICU, so a secure ward, for about 4 or 5 years, and that's when I started to learn about open dialogue. And we would have people who would come to us, and we would sometimes start work with some of the families there. Then they would go back, and none of that work would continue, and then they end up coming back to us. And what we found is that sometimes the dialogue with the families would make such a big difference that surely, an ideal system would need to incorporate that into our longer term care. I'll give a small example of my kind of pre-open dialogue life. I remember in PICU with a young man who was very disturbed. He was very difficult to understand, sort of word salad, if you like, in terms of his experience, hard to form logical conclusions between his words. We couldn't really understand what he was saying, but he was talking clearly, but that we couldn't really follow his language. We invited his sister. We had a meeting together with sister and the family member, and suddenly halfway through, what he was saying, she said, "This is all about our dad." And then following from that, there was a large description of the story of their father, and who was actually suspected of paedophilia, not against them, but in the newspapers, and how that affected them in their childhoods, and how that had a major impact on, and actually relates directly to the specific words that he was describing at the time. Around that time, increasing amount of literature was coming up about the extent to which trauma is a fundamental antecedent to people ending up in our services. And the core reason why most people end up in our services is because some kind of trauma or events in their lives prior to coming to us. However, most of our services are geared towards dealing with the symptoms rather than the cause. So it's a bit like, I kind of sometimes liken it sort of like to a cardiologist treating pain rather than the underlying sort of heart disease. So really thinking about actually how do you engage families, and how do you engage families to understand what's happened, what the journey is. Then I started to hear about this thing called open dialogue. Now this was originally invented in northern Finland. And what happened there is that they had some of the worst outcomes actually in mental health in the world. They had some of the highest suicide rates and worst relapse rates in the world. So what they did is they actually shut down a lot of their services and restarted them as a series of experiments in different regions. And one experiment they tried in an area in northern Finland was called open dialogue. And what that involved was training every family member, every member of staff, every member of the team, every psychiatrist, every social worker, every nurse, every OT, everybody in the team in family therapy or related skills, so that their perspective was systemic. From the beginning, they were working with everybody, with the network, and not just the patient on their own. So whenever there was a crisis, their goal was to, okay, let's see who we can bring together. The first question in open dialogue is very much, who else is important to you? Who else is important to your life? It might be a neighbor, it might be a school friend of old, it might be a colleague, it might be a parent, it could be anybody. Who else is important? Who else would you like to bring into the room? And really emphasize that. Now, the CQC do an annual survey of service users across the UK, 15,500 roughly, 14 to 15,000 service users complete this survey every year. And a regular question in there is somebody who was, the people who are most important to me were involved in my care as much as I would like. And successive years, that question always comes in at less than 50%, meaning over half of the patients in mental health services in the UK respond saying that actually my loved ones and people who I want to be involved in my care are not involved as often as I would like them to be. So all you have to do is ask the patient, and they'll bring a whole lot of people into the room. I first started talking about open dialogue when Norman Lamb was Minister of State in the Department of Health. And some of you may know that he is a carer for his own son. And he told me that he found it difficult to get involved in his own son's care, and yet he's Minister of State in the Department of Health. So if he doesn't get to do that, then how easy is it for anybody else? So our system is not really geared up often to working, sort of bringing the family together in terms of thinking about the treatment as something that we're going to do as a group and involve them with as much as we would involve the patient. And then training their staff to think systemic. Now, when I went through my open dialogue training many years ago now, it was very much a revelation in terms of trying to understand what I'm seeing before me as part of a wider system, that, you know, it's part of a story. And in the open dialogue meetings, which I've done probably hundreds by now, with the families, I start to see within the first few meetings, usually somebody in the network will say, maybe we should talk about it. And then they start to pluck up the courage to talk about that which has not been spoken about much up to now. And that's usually part of the reason why they're here. It's usually related to some of the incidents and traumas and difficulties that have happened in life up till now. And we're creating a space to try to enable that to happen by learning these new skills. Open dialogue is not about abandoning anything, but it's about learning new skills to help us work in this systemic way where we bring other people into the room and work with them in a way that they feel heard, that there's an open space, that we're not sort of jumping in there to provide answers quickly. And then they can start to find ways to understand it themselves in the context of the stories they've been through in their lives. And when they start to do that, you know, some significant shifts start to take place, often very quickly, in terms of understanding where some of these sort of what we describe as symptoms are coming from. You know, some of these experiences relate to, and that has a profound effect. Now, where we do in our current services engage in understanding those incidents tends to be in psychology. However, we tend to have psychology here, and you know, sort of what the rest of us, what the psychiatrist and the team is doing here, they're sort of not fully connected. So we're usually in the same room, you know, and we're usually engaging together. And we're usually utilizing those skills and thinking about those understandings as a group together. And the training in open dialogue very much involves facilitation. It involves how to find a way to create what's called polyphony, to ensure that every voice is heard. And we believe that a lot of what's happening is because all voices aren't being heard, and that might be the voice of the patient, or it might be people around them. And it might be really sort of underlying this, fueling a lot of this, is that the difficulty in grappling with the experiences that they've been through. And it's always they, because it's very rarely an individual who's been through the experience on their own. It's usually a group of people, family members, who in some way have also been impacted by it. So really to approach it in a holistic way involves approaching all of them and hearing from all of them and sharing with all of them. And also the answers are coming from all of them because they're the ones who've been through it. So, you know, open dialogue therefore means that we need a system that involves continuity of care. Now, in our general adult services, that is missing. In forensic services, actually, that is a bit more present. But in general adult services, you can go from one team to another team to another team. When I worked at a PICU, sometimes people have been in 4 teams in the last couple of months only. And so that doesn't really facilitate a relational form of care and continuity happening. So one of the core principles of open dialogue is continuity of care. Some of the first people who assess them in crisis should be the ones who continue with them throughout. Another core principle, as I say, is involvement of the social network from the very beginning and making an emphasis on that. Who else could be involved? And other core principles involve things like really working to create polyphony, tolerating uncertainty so the clinician doesn't jump in there with ideas and answers quickly. That creates a space where the family can then start to fill the gaps and really help to understand what's going on. That's how you create a collaborative atmosphere. So they also feel valued, their perspectives, their understandings, their sort of story that they can start to knit together by sitting together in this way starts to come out. So that's kind of in a nutshell, if you like, so how open dialogue works. Part of the training we do to help clinicians work this way involves things like mindfulness, you know, teaching clinicians actually to be present with our own distress. And by doing that, it enables us to become present with the distress of a network, because that's what will often happen when you bring people together. There may be some distress, and we're okay to be able to handle that if we can handle that in ourselves first. But you know, we try to create an atmosphere that is open and respectful, and therefore enables a dialogue to occur where deeper meaning can be sought, you know, through the network as much as through anybody else in any other sort of paradigm or understanding. As I said, when they started to work this way, they started to train their staff to work this way and orientate their service operationally to deliver their service this way in Northern Finland. They found some quite remarkable things, really. They found that 74% of all of their service users who had a psychotic presentation had left services within 2 years. Then that went up to 86% after 5 years. And even to this date, that data stands. So I'm in touch with them all the time. And they tell me how that original cohort, for example, in the 1980s, still haven't come back to services after all this time, 74 to 86% of them. That is a lot higher than in this country, where most people who have a psychotic presentation end up staying in services long term. So now that was considered an outlier, that data, and it wasn't really factored into a lot of meta-analyses because it wasn't randomized. Okay, they basically looked at what their outcomes were and how they changed pre and post open dialogue. So there hasn't been a randomized trial in open dialogue yet. And so we put in an application to the National Institute of Health Research to run a large-scale randomized controlled trial in open dialogue. And that was funded a couple of years ago. We're right in the middle of the trial. We had to pause it a little bit for COVID, but I'm happy to say that we're restarting it again now. And that involves sort of 7 trusts across the country and a group of teams, which are sort of crisis and home treatment and recovery teams working together along the open dialogue model to deliver care in this very different way. We aim, therefore, hopefully, to show a major difference in outcomes, in relapse rates and hospitalizations and things like this long term for people. As I say, this is mainly going on in adult services, but what we do hope to do eventually is to widen the conversation, to CAMS, to older adult services, and to forensics too. And in forensic services, there is some evidence of some utilization of it. A friend of mine, a colleague of mine who's the sort of service lead, the consultant psychiatrist and associate medical director in forensic services for my trust, who runs a low secure ward. And he did the open dialogue training, and he found it hugely useful in his own services as a way of conducting all of their meetings actually along open dialogue lines, creating that open space, and always involving family wherever possible, involving other members of the network, so that the dialogue always involves all of them, and the staff are trained in utilizing those skills to bring people together, to create open a space where voices can be heard. And they found some significant improvements and changes in people's lives. One evidence, I guess, that we have of the efficacy of that was that our trust at the time, this isn't the last report, but a couple of reports before from the CQC, found our trust to be requires improvement. The only part of the trust that got an outstanding badge was the low secure ward where they were doing open dialogue. And actually open dialogue has been successively cited in a number of CQC reports, in my trust and others, as an example of best practice. So it was kind of recognized as a way that was making a big difference to people. So I think that there is a future in open dialogue in psychiatry generally, of course. It's been actually utilized around the world in a number of countries now. There's about 5 or 6 states in America which are investing in it heavily. And downtown New York and Manhattan had an open dialogue service since 2012. So there's a lot. We also have peer workers in our open dialogue service. So people with lived experience are core to the team. That way they can reflect the value of lived experience, which we see as a qualification and understanding in its own right. And we have family members sometimes join our teams too. So let's say it's a different way of working, it's a different perspective, but it doesn't exclude anything. It's about bringing people and perspectives together so we can have a dialogue with each other. We're sort of halfway through our trial in the UK now. We hope to be able to spread it out further, and just glad to be able to talk to others about it here. And Noel and others who have heard about it for some years have also been thinking for some time about its application in forensic services, and hopefully we'll be able to get there and bring some of this into the forensic system eventually, but at least have a dialogue about it, I think, with colleagues and others in due course too. So thanks for inviting me.
Thank you very much, Russell. That's such an interesting new, it feels it feels like it could revolutionise mental health and the way we do things. I think it's really exciting. I'm really keen to hear how the trial goes. So we've just got 5 minutes left. So big thank you to all the speakers today. It's just been such an interesting, varied talk from everyone. So if anyone's got any questions, please do put them through. We've had a couple of things through on the chat function. And one of the questions that has come through is directed to Sheena, but I presume that I'd be keen to get both Neela and Sheena's responses really. So the question is, you mentioned being made to feel welcome when visiting your son in High Secure, and so the question is based around how did the team achieve this? So I think this person's really keen to get sort of really practical tips on how to engage family members early on in the patient submission.
Thanks, Kate. Yes, I can read it here. it wasn't actually, when my son was in high secure, I was certainly never made to feel welcome, but I was made to feel very welcome in medium secure. And it's simply being met and walked to the ward and being asked about your journey and being able to feel that you can talk about your relative. So you can say, well, how's he settling in? So somebody's actually able to engage with you straight away. But I also think there's something around being proactive, and I was interested to hear Melanie talk, because I'm aware she mentioned my friend who has a son there, and they go out and actually take a personal history with carers. So they actually, someone from the unit will actually visit. And I talked about developing protocols for carers, and it's things like inviting them in, telling their story, giving them space to tell their story, giving them, you know, often you want to talk about your relative, you want to tell them, you want to tell services what's good about them. You don't want to go over the past, but you do want to sort of be aware. So there's actually being able to talk to somebody when they first arrive, giving carers space to talk about how they feel and to listen to their story. You know, how does it feel now your son's here? Did you expect it? You know, tell me a little bit about yourself. You know, things like that, that it makes you feel valued, it makes you feel that you can trust the services, and that means that people can get on with their job, and you can feel secure in the knowledge that they do care about your relative. I'm just going to, I'll let somebody else carry on. I do notice that somebody said, how can we enhance your involvement as a carer with consent from your family member? I mean, the point I was trying to make is that you do not need the consent of our family members to make us feel welcome, to talk to us as human beings, and to ask questions about our relative. And those three things are really so important to us, because we know who they are. As I said, you know, we hold what happened to them in our heads, and we know them as people in our hearts. And I'd really like that to be recognised. Thanks, Kate.
Yeah, fantastic. Thank you, Sheena. Nuala, would you like to add anything to that about, I guess about how to best make family and friends feel welcomed, and your experiences of that?
I agree with what Sheena said. You know, just sort of normal human friendliness, smiling, asking about your journey, that sort of thing is really important. And that does generally happen. I have to say that most of the staff are very friendly and welcoming. But you know, it's really having a voice is the most important thing to me, having my voice respected, because you know, I do know my son very, very well, and the things that have been listened to have actually made a difference to their way of understanding him. But I have actually had to more or less push that on them rather than being invited. So that's the thing that concerns me most, is to be seen as part of the team.
Yeah.
Yeah.
Also said to knit everything together. I think that was a good way of saying it. It makes it stronger, doesn't it?
Yeah.
Fantastic. Well, I think we're going to have to round up there, as it's 5:01. But again, a big thank you to Sheena, Russell, Melanie and Nuala for their contributions, sharing their experiences. Thank you to everyone who's attended as well. I'm really, really pleased, and I hope you've enjoyed it. Gem's just sharing there an opportunity to give us feedback. If you hold up your phone to the QR code, then it will take you to the link. We've got another few open discussion sessions that are coming up for the Quality Network members. So these are on topics around the use of technology within forensic services, managing risk and patient pathway, and then the final one will be on lessons learned from COVID, to round things up. So if you'd like any more information on that, please do get in touch. And as I said, we're really keen to get your feedback. So if you'd like to just give us feedback through the QR code, or we'll send you an email afterwards. But yeah, thank you everyone for attending.